Okay, everyone, for the sake of time, I think we're going to get started. I think we've lost a few people. Everyone wants to be outside for this weather. But I would like to formally introduce Dr. Carolyn Givens. Is that how you pronounce it? It's basically coming from San Francisco, and she's a reproductive endocrinologist. We've talked about a lot of topics, but one of the most amazing things that we are trying to help with is fertility. And this is, patients are living longer, they're living into their adult years, and these are topics that I get every week. I'm getting married, we're thinking about children. We don't know how to do this. And we have some wonderful colleagues that can help us out with this. At Stanford, I tend to do all the genetic counseling for this, but after the genetics, I need help. And that's why we asked for someone like Dr. Givens to help out with us. So I'd like to give her a welcoming hand of applause, and we'll get to hear a talk from her.
Thank you so much. Thank you. Well, now for something completely different. I named this talk When Worlds Collide because prior to about 1992, there really wasn't much in common between the worlds of cystic fibrosis medicine and my field, which is assisted reproductive technologies. But starting around 1992, there were some technologies that were developed that really brought our worlds together in a couple of ways, and that's what I'm going to discuss today. Two areas that I'm going to be discussing are congenital absence of the vas deferens, which is a condition that affects some male cystic fibrosis carriers and some male cystic fibrosis patients as well. And I'm also going to be discussing the area of pre-implantation genetic diagnosis. That is, being able to diagnose the presence or absence of the cystic fibrosis genes in 5-day-old embryos before they get implanted into the mother's womb. So the first condition is congenital absence of the vas deferens. This is, of course, a Netter drawing showing the testicle here, and then the vas deferens is the tube that connects the testicle and brings sperm down to the urethra. In a certain proportion of cystic fibrosis carrier males and cystic fibrosis patients, that tube is actually missing at birth. And it's very easily diagnosed because it can be palpated in the scrotum. And if it's not present there, then you can just feel the scrotal vessels, and there's none of this firm tube that you would normally feel. So of course, this renders these patients infertile. It's estimated, it's not known for certain, but it's estimated that about 5% of male cystic fibrosis carriers are born without a vas deferens. Obviously, it doesn't affect all CF carriers, or CF would cease to exist as a disease and not be passed on to their children, but it does affect about 5% of CF carriers. It results in a condition that's called obstructive azoospermia. That means azoospermia means no sperm in the ejaculate, and it's an obstructive condition because it's simply an obstruction between the testicle and the ejaculate. The treatment for this in men is to undergo a surgical procedure, either a microsurgical epididymal sperm aspiration or a testicular sperm aspiration. And unfortunately for the wives of these patients, they have to undergo in vitro fertilization in order that we can get the eggs. And the reason is that sperm that comes from the epididymis, or the testicle, is not like ejaculated sperm. It doesn't have the capability of binding and penetrating to mature human eggs. So we actually have to take these sperm and inject them one at a time into their wives' eggs in order to get these eggs to fertilize. And this is the procedure that I'm going to show you a little bit later, called ICSI. The success in obtaining sperm through a MESA or TASA procedure is virtually 100%. The sperm is there, it's functional, except for being able to bind and penetrate an egg. It's got all the DNA it needs to fertilize an egg. The success in obtaining a pregnancy then is going to depend on various other factors, female factors like the age of the wife. Obviously, the younger the better. So this is just a Netter drawing of a MESA and TASA procedure in a testicular sperm aspiration under anesthesia, a local block. You can just go into the testicle with a needle and aspirate sperm directly from it. if you want to get millions of sperm to be used for more than one IVF procedure in case there's concerns about the wife's age and maybe she'll have to go through multiple IVF processes in order to achieve a pregnancy or more than one pregnancy, then the urologist, who's a specialist in doing these types of procedures, will open the tunica of the testicle and go in and snip out some of the epididymal tubules, which is a collecting system that collects sperm from the testicular tubules. And it's there they can obtain millions of sperm that can be frozen and used for multiple procedures if necessary. So one of two options on trying to obtain sperm. So then the in vitro fertilization procedure, which I'd like to describe to you now. In this procedure, we have to recruit the wife to make multiple eggs. We retrieve the eggs under an anesthetic procedure. We inseminate the eggs through the ICSI process, and then we transfer the resulting embryo back to the uterus. This just shows an ultrasound after a woman has taken about 10 days of fertility medications by injection. The ovaries become enlarged and they fill with follicular fluid, and in each one of these follicles there is a microscopic egg, and we can go in and remove them through a minor procedure done through the vagina, again under anesthesia, and we watch with ultrasound as the needle comes into the follicle and we aspirate that fluid out. Our embryologists then are looking for the human egg, and this is basically what a human egg looks like. I wonder if we can get the lights dim because I'm going to have some videos to show, and they'll probably be easier to see in a minute with the lights dimmer. Thank you. So this is a human egg surrounded by its protein coat called the zona pellucida, and inside the egg it has half the chromosomes that the mother has. It's obtained now half of its chromosomes that are being passed on so that the sperm can come in and bring in its half set of chromosomes to create a new human being. In the ICSI procedure, this is done in the laboratory, and this is the procedure that was invented in Belgium in the early 1990s, and between 1992 and 1994 or so became a worldwide procedure. It really revolutionized the treatment of male factor infertility because we use it not just for CF patients or for azoospermic patients, but we can use it for men who have very low sperm counts as well. But the embryologist has to sit at a micromanipulation station that dampens their tendency for little tremors that we might have, because they're dealing with injecting a single sperm into an egg using a needle that's about the size of your hair, a human hair. And this just shows, I think I have an extra slide here. Okay, so now if you watch, that needle just picked up a sperm. The sperm, you might have a little hard time seeing this in the back, but the sperm is right there at the very edge of the needle. And now with a holding pipette, holding the egg, the embryologist is going to bring the sperm up really close to the end of the needle and then inject it directly into the egg, which looks a little bit brutal, but the egg tolerates it quite well. And now the sperm is being pushed into the egg. And amazingly, about 70% of the mature eggs that are treated this way will successfully fertilize and create a new human being. So this is done on the same day that the eggs are removed from the wife. And it's done possibly on the same day that the husband had a testicular sperm aspiration, or if we're using microsurgical epididymal sperm, we can use frozen specimens of sperm as well and just thaw them, pick out the best looking sperm we can, and inject it into the egg. They really do look different, so we got to pick out good ones. Really handsome ones, yeah. Okay, so then the next day after that, after the egg has been injected, we look for this. That's called a zygote, or a 2-pronuclear embryo. It has a nucleus from the egg and a nucleus from the sperm, and they're all lining up to recombine their chromosomes to create a new human being. 2 days after the sperm injection, the embryo has divided into 4 cells, and 3 days, 8 cells. Then the divisions start becoming quite exponential and quicker. And so by the 5th day of life, this embryo is now called a blastocyst, and it has about 100 to 200 cells in it. And it's really a three-dimensional structure here. We're looking at a two-dimensional view of a three-dimensional structure. And on one side of it, we'll see a part of the embryo that's starting to become the embryo itself, the fetus itself. And then cells that are flattening out around the edge of the embryo that are going to become the placental cells. And so this is usually the stage at which we would transfer an embryo back to the wife's womb. And that's a simple procedure in which we just put a speculum in the vagina, load up the embryo in a little catheter, soft plastic catheter, and put it up into the top of the uterus and deposit it there. And then we wait 9 days to see if the woman is pregnant. So that brings me to the second part of what we do with cystic fibrosis, and that is to try to determine in families at risk to have a child with cystic fibrosis. Maybe they've already had a child with CF, or maybe that through propitious genetic testing, they already know that they're both at risk. And now the American College of OBGYN, as well as most medical genetic organizations, are recommending that everyone be offered testing for cystic fibrosis carrier status. We like to see this extended to preconception testing before patients are pregnant, so then they have the option of finding out if they're at risk and being able to do pre-implantation genetic diagnosis. So, of course, this is a procedure that's for couples who are at risk to have a child. So both the husband and the wife are carriers for one of the many mutations that are responsible for the disease. And we can diagnose an embryo as either being affected, unaffected, or being a carrier. And we can diagnose this in the IVF lab prior to transferring that embryo back to the patient. It then precludes needing amniocentesis or CVS, because we know that that test is going to show what the pre-implantation tests show. But it does require in vitro fertilization to be done in order to get the embryo in the lab to be tested. So these are couples who have, generally they don't have any fertility factor risk. They're not infertile necessarily, but they want to know that they are not going to have a child or another child with cystic fibrosis if they can prevent it. So going back to the embryo development stage, we grow the embryo, we do the in vitro fertilization process on the wife, we obtain the sperm. Most of the time, there's not congenital absence of the vas, and we can just mix the sperm and egg together and let the best one win and let the sperm fertilize the egg themselves. And then we get to the 5th day of life, and this is the stage at which we're actually going to remove the cells to analyze the embryo. Again, we use a micromanipulation setup because we're dealing with 400 times magnification. We're dealing with, although the human egg is the largest cell in the human body, the human sperm is one of the smallest cells, but the human egg is one of the largest. And a blastocyst is about 1/10 of a millimeter, so it's very, very tiny. And it has to all be done under the microscope. And it's amazing that this can be done, actually. This is a biopsy procedure, and hopefully this video will work. Oops. I'm not sure what I need to do to get that video working. Just hit the... Okay. Oh, I got it, yeah. Sorry. Okay, so this is just showing, we're coming in now with a bigger needle, a little more blunt on the end. We've created a hole in the zona around the egg, and that's allowed part of the placental cells to come out of that embryo. And it can be just gently pulled off. And these cells then are going to be sent to the laboratory that's going to do the analysis for the CF gene in this new individual, this new embryo. And the embryo itself is going to remain in the IVF laboratory. So in the IVF laboratory, we freeze the embryos in specially marked and coded straws so we know which embryo goes with which biopsy. And they get vitrified or frozen in a very, very low liquid nitrogen temperature storage system, waiting for the results of the biopsy. The biopsied cells then go off to a lab, and currently we work with a lab in Redwood City called Natera. And what they do is they take the cells that we've given them in a tiny little test tube and they amplify the DNA. They do whole genome amplification so that they've created millions of copies of all the genes in the entire embryo. Okay? And they've also taken blood cells from the mother and the father so that they can compare the genes that are present in the embryo to the genes of the mother and the father. This, I'm not going to go into this. Could be a whole technical talk in and of itself, but basically they look at 300,000 sites in the human genome because we're looking not just for the CF gene, but we're also looking to see if the chromosomes are all present and accounted for in the right numbers. So they can tell whether that particular embryo that we've sent by the pattern of the analysis contains an affected CF gene or not, and it can tell also whether there's the right number of chromosomes. So is this going to be a male embryo or a female embryo? And is it going to have 2 copies of every chromosome as it should? Or are there missing copies which may result in the embryo not implanting or miscarrying? Or could there be extra copies which could result in Down syndrome or some other abnormality? So we get 2 types of information. Is this a CF affected embryo or not? And does it have the right chromosomes? So this is why we want multiple eggs, because we need to overcome the fact that, especially as women get older, there's more abnormalities in the chromosome number. And of course, 1 in 4 embryos theoretically are going to be CF affected. So when we get the analysis back, then we simply pick out an embryo and we put it in the uterus. This is just a catheter going into the uterus to place the embryo in to transfer it back to the wife's womb. And again, we wait 9 days to see if they're pregnant or not. And if they are, we're very much rejoicing. But if they're not, unfortunately, they may have to do the procedure again. Although we may have frozen embryos in addition that we keep frozen that they could try with and not have to go through the whole procedure. So basically, just in conclusion, cystic fibrosis patients and carriers may have a reason to seek help from people like me and to avail themselves of using assisted reproductive technologies. The MESA and TESA procedures, which were developed along with the ICSI procedure in 1992, really have led to the ability of males with congenital absence of vas deferens to have children. And now we can screen embryos prior to their implantation, and it allows us to stop the disease before it gets started in the next generation. And that's been really a very rewarding thing to be involved with. So I'd like to thank several people, including Mary Helmers, who's in the back of the room, who invited me to this talk. And Lori Black, the genetic counselor that we work with in our clinic, Dr. Joe Conahan, who's our lab director, who really brought all these technologies together for us, and Matthew Rabinowitz, who's the CEO at Natera, who really developed their whole system and the ability to do single gene analysis as well as 24 chromosome analysis into play. And I'd also like to thank all the CF families that I've had the privilege of working with in the last 20 years. It's been a real honor. Thank you very much. Are there any questions? No? Yes, ma'am.
What is the cost of having this procedure?
The cost of undergoing a procedure for, say, for pre-implantation genetic diagnosis, for doing that. The IVF procedure itself with ICSI and medications is probably around $16,000. And then to go through the testing of the embryos and then come back for a frozen transfer later, that total cost is about $23,000. We've really been trying to get insurance companies to see the benefit of this, to prevent CF births if we can. It really would be in their best interests. However, being insurance companies, they kind of tend to be a little bit short-sighted, and if the patient doesn't have a fertility diagnosis or doesn't have fertility coverage under their insurance plan, then they have to pay out of pocket, pretty much. Yes, ma'am.
Have you ever seen an error in which a woman has gone through PGD and IVF and then still ended up pregnant with a CF positive?
So the question is, have I ever seen an error in the diagnosis at the genetic level? The error rate is somewhat theoretical. It's probably 1% to 2%. I haven't personally been involved with anybody who had a CF error in diagnosis, but we've had some in the chromosome diagnosis. We've been involved with some errors in sickle cell anemia, because you can imagine we can do this now for every gene for which, the mutation is known for that disease. And so we do it for many, many diseases besides cystic fibrosis. Fortunately, the error rate is quite low. Now, that begs the question, should you go ahead and do CVS or amniocentesis? You just have to be counseled about what that error rate is and decide for yourself how important it is to get a secondary confirmation of the diagnosis. Yes, ma'am.
When you're screening for the CF genotype or carrier status, do you use the 32 gene or the whole available?
The question is, when we're doing general population screening, do we use a limited panel or a more expanded panel of mutations? It's a good question. I would say that for most Caucasians, we just use the limited panel because that's what's covered by their insurance. If we find that they are positive, then we will test the husband, or vice versa. If we find the husband's positive, test the wife, the other partner, using either an expanded panel or even sequencing, depending on their ethnicity and also what their risk tolerance is. Because a lot of times, unfortunately, those expanded panels are hard to get covered by insurance sometimes. Okay, thank you very much. I really appreciated being asked here.
Okay, guys, we have one more talk. I'm just going to ask for a favor. We have a little treat from the of this mug that I was told we're offering. So if you'll just look underneath your chair, I was told that there is a marker there. Whoever has the marker has the mug. If you don't fall over on the chairs, people. All right. Or if you're not in that chair and you find a chair with one, it's yours. Otherwise, it's mine. All right.
Oh, it's yours.
It's all right. There you go. There you go. Okay, guys. And for the last talk, I'm actually pleased to introduce one of. Yes. What you need? Is this the right slide?
It's not. It's my slides from this morning.
Okay. Well, in the interim, I am pleased to introduce one of my social workers, Meg Dvorak, who works specifically with our CF patients. We have had a fantastic time working together, and in fact, we're going to be publishing very soon a paper which is dear to both of us that Meg will be talking a little bit about, or perhaps a lot about. In my talk, I introduced one specific slide about the other issues we have to worry about above the age of 18, such as we're seeing more diabetes, we're seeing osteoarthropathy, osteoarthritis, and we are also seeing a higher risk of developing depression in our patient population. In fact, the most common after the age of 40, as I mentioned, was diabetes, followed quickly by depression thereafter. when you looked at the curves before, the depression curve was going up exponentially. So we believe that that's a higher risk factor. Meg is going to spend some time talking about depression and how it's incorporated into our CF care model. All right, Meg. Thanks.
Is it better to dim the lights? Is it easier to see? You guys want the lights out? Okay, that's better. So thank you for that introduction, Dr. Mobier. Can you guys hear me good? I know I'm the last lecture today, and I know everybody's been sitting for a long time, so I promise not to depress you guys with this topic. But rather, I just want to actually talk about this more because it's common. I want to increase awareness about depression. It's very under-recognized and thus under-treated, not just in CF, but in the general population. So I've been working on a QI, a quality improvement project at Stanford, in partnership with Dr. Mobier, taking an in-depth look at depression. So today I wanted to share with you some of that information that I found not only in the literature, but also some really interesting data that we have right here at Stanford. And this is my list of objectives. I hope to leave some time at the end because I know Cammie has a lot of questions, and there may be others. So we'll go ahead and get started. This is a list of the most common disorders that you'll see in the DSM-4. That's the Diagnostic and Statistical Manual, 4th edition. The new one's coming out in May. So major depressive disorder, probably the most severe form of depression, also known as MDD. I'm going to be talking about that in a couple more slides, some of the symptomatology that you need to qualify for that diagnosis. Dysthymic disorder, or also known as dysthymia, is a more mild form of depression, more mild symptoms, and a more prolonged course, 2 years or longer. Adjustment disorder with depressed mood is a depression that results from an identifiable stressor, perhaps a loss of a job, perhaps a divorce, something of that nature. The symptoms tend to last about 6 months, and they remit once the stressor is terminated. And depressive disorder, NOS, non-otherwise specified, is just a set of depressive symptoms that doesn't seem to fit into other categories. Other types of depression, sort of more non-clinical, that you'll hear talked about are hospital depression. When a patient gets admitted to the hospital, particularly in CF, they tend to stay for long periods of time, sometimes 2 weeks, sometimes longer, and they can develop a depression in the hospital. The loss of a consistent routine, the insomnia, food changes, being woken up all times of day and night, that can really take a toll on a person. Situational depression, or also known as reactive depression, a depression in response to something going on in your life that's not going well, as I talked about with adjustment disorder, a loss of a job, a loss of a relationship. And I think particularly in CF, as the disease changes and progresses, development of maybe new comorbidities can be a time when a person can develop depression. And then seasonal depression, also known as seasonal affective disorder, can be a depression that arises at certain seasonal times of year, most likely in the fall, in the winter seasons when there's not as much light out, you're not outside a lot more, can't be as active, and particularly for CF patients, they tend to get more viruses, colds, flus, and they're hospitalized more often. So this is the criteria for a diagnosis of major depressive episode or major depressive disorder. 5 or more of the following symptoms on this list are present for the same 2-week period. And these symptoms cause clinically significant impairment or distress, and they represent a significant change from previous level of functioning. 1 of the 5 symptoms must be either depressed mood or diminished pleasure in activities, also known as anhedonia. I think it's challenging to formally diagnose a CF patient with depression because there's some overlap with some of these symptoms. weight loss or malnutrition, insomnia from chronic coughing, fatigue, and even thoughts of death or dying are common in the CF disease. So how common is depression? Well, very common. So common, it's often referred to as the mental health equivalent of the common cold. And it's more than twice as common in women and men. Up to 17% of the general population has had depression at some time in their life, and up to 9% has been diagnosed with depression in the past year. So that's a lot of people. It's very common. Studies across a wide spectrum of disease lines indicate pretty much unanimously that depression rates are higher in chronic illness populations. The good news is that depression is very treatable. The bad news is not enough people are recognizing it and actually getting that treatment. So we're all very familiar with that intimate mind-body connection. I think this concept is best illustrated when you think about the impact of stress. When a person is stressed, they tend to get migraine headaches, stomach aches, muscle tension, neck aches, blood pressure problems, a whole variety of bodily symptoms. Similarly, depression takes a heavy toll on the body. People with depression tend to have lower immune functioning. They get sick more often, they stay sick for longer, and they're hospitalized more frequently. The research shows that stroke rates are 2 times higher in depressed people, and there's even a study that shows that depression can precipitate people for development of other chronic diseases. Probably the largest body of research looking at depression and chronic illness is in cardiac medicine, probably because it's so common. But the study shows a strong correlation between depression and having a negative impact on the body. Depressed people tend to die earlier too. Negative impact on the body, suicide, and just poor self-care in general. In my own practice, I've often seen that CF exacerbations in my patients are often precipitated by a time of stress. So depression in the CF population, the prevalence rates vary widely. Some of the newer studies are showing depression rates as high as 30% and more. And then some of the older studies are showing depression rates are no different from the general population. So it's kind of all over the map, and I'm going to be getting into that in a few slides down. But I think it's so important to consider the shifts in this disease over time, how the disease has evolved. What was once a disease of childhood that was considered terminal has now turned into a chronic disease with a very protracted life course. And so, and also, people with advances in lung transplant and the frequency that that's being done, more and more CF patients are considering that as a treatment of choice at the end stage. And so this is really a chronic disease. And physicians and caregivers are turning more and more to mental health professionals such as social workers, psychiatrists to help patients manage all of the complexities of managing this disease in adulthood with all of the other demands that are normal for an adult person. Just another tidbit, I know I'm not talking about anxiety today, but in most of the studies, anxiety seems to be a lot more common than depression. So in looking at specific risk factors for depression in CF adults, I came up with this partial list here. This is based on what I've seen in my own practice, in the literature, as well as some of the themes that have come up in my support group. And I would say the biggest factor would be that burden of care, that daily, time-consuming, tedious, if you will, CF care regimen. And I'm going to be illustrating that more in my next slide. And I think that when patients have, their care continues to increase as they age, it just becomes harder and harder to stay on top of it. And when patients aren't able to do it all the time, feelings of guilt, shame, feeling criticized by family, spouses, and even the CF care team can create feelings of depression. Losses on so many levels, losses of relationships, losses of friends to CF, very real in this community, and other more existential losses, like loss of the career I hope to have because I went to college and now I can't work, a loss of a relationship, a loss of being able to have children, and just a loss of a normal life. This is a very isolated population. We know that. There's probably quite a few CF patients watching this on stream because they can't be here today. They can't be together for a variety of reasons. So many CF patients, for whatever reason, end up staying home a lot. They want to avoid germs, infection. They spend a lot of time on their computer, on internet sites. Lack of energy and breathlessness, this is especially difficult for young adults who in their 20s, they want to keep up with their friends, they want to go hiking, they want to travel, they want to go out to clubs at night with their friends, and they just cannot keep up. And so they tend to feel a real disconnect with their peers, and then over time they get more and more isolated and more alone. And I think that flows into the next one, relationship problems. I've heard so many CF patients tell me, I feel unworthy. I feel like I shouldn't have friends because I can't really give very much. I'm sick a lot, I have a lot of needs, I can't go out with you, I have to cancel a lot because I feel sick, and so they just end up feeling unworthy. Also, the CF is my child comment. So many people say, oh, CF is like the child I didn't have because I have to take so much care of it. It's so time consuming. Adults who are more advanced in their disease often are unable to work. And we all know the SSI income does not support a person in this area. So they end up feeling dependent on a parent or a spouse or a roommate or someone else, creating feelings of depression. And we all know that addiction to drugs, alcohol, pain prescriptions is highly correlated with depression as well as other mental health problems. So this is that slide I was telling you about. This is an actual patient schedule. This is an adult CF patient who has more advanced disease, sinus issues, arthritis, and diabetes. So clearly this person does not work. From the time they get up to the time they go to bed, this is their schedule. They take care of their CF all day long. There's maybe a couple little breaks in their day where they make phone calls to doctors, go to the doctor appointment, but everything that they do, including eating, rest, and exercise, is somehow part of their CF care. I don't know about you guys, but I don't know. Does anyone think they could do this every day? Can I see a show of hands of people who actually think they could do this every day? Just out of curiosity. So people who are depressed are more likely to harm themselves or commit suicide. However, in CF, the numbers are relatively low. In 2011, according to the registry, there's only 2 deaths to suicide out of 444, and total deaths altogether is 23 out of more than 10,000. So although those numbers are low, it's still tragic that the deaths could have possibly been prevented. I think more importantly, we need to look at the longer trajectory and mortality when it comes to depression, in that so many of the studies show a strong correlation between depression, noncompliance, negative impact on the body, poor self-care, and premature death. Just more expedited disease progression. Passive suicidality is, a patient is considered passively suicidal when they have depression that's so bad, it's so pervasive, it's so debilitating that they lose the will and the drive to take care of themselves, and they basically just give up. And although they might not have active intent to harm themselves, they passively let the CF do it for them. I've seen this happen in more than one patient, and it's very sad. So in looking at the literature review in CF, probably the most valid, up-to-date, and groundbreaking study on mental health is the TIDE study. This is a multi-center, multi-country study screening for depression and anxiety in CF patients and their caregivers ages 12 and up. And then they go ahead and they link that data with other health metrics and health outcome. And so I have the German arm of this study has been published, and they found elevated anxiety in 20% of their patients associated with a recent pneumothorax, hemoptysis, or diagnosis of diabetes, but depression no different than the rates in the general population. Of the patients that did test positive for depression, they had lower FEV1s in a transplant listing, not surprising. This is some more recent data from the TIDES group from last year. The HADS is another way to screen for depression. It's called the Hospital Anxiety and Depression Scale. And the CESD is the Center for Epidemiological Studies Depression Scale. And that's a more thorough look at depression. So you can see the differences in the depression based on what scale the patient used. So USA came out at 30.2%, much different than the German arm of that study. I don't know what's going on in Turkey, but there's a lot of depression there, 42.9. Here's another study that came out last year out of the UK. Depression found in 17% of patients, anxiety 33%. Interestingly, depression was associated with a poor quality of life, not surprising, lower BMI, lower FEV1, and higher rates of rehospitalization. However, not associated with gender, age, or other comorbidity, unlike the general population where twice as many women than men are depressed. Another ongoing study in Arkansas found 15.9% prevalence of depression associated with older age, lower education, more frequent hospitalizations, and less religious commitment. Just kind of looking at different metrics. A study in 2007, 30% depression. So these results are sort of all over the map. It's really hard to get a grasp on how common this is. So how do we measure up? This is the 2011 data from the Cystic Fibrosis Foundation. Unfortunately, the 2012 data doesn't come out for several months, so we had to use some old stuff. But our center comes out at 12.9% rate of depression, the red line. Pretty far below the national average, which is the green line. The perception at the Cystic Fibrosis Foundation is that depression is underreported and thus undertreated. The way it's reported isn't through like a special screening tool. It's actually just through it being checked off in a box on an encounter. So we probably need to improve that for the future. This is looking at the same data, but going back 5 years. The national average seems to be a pretty steady line with a slight increase. Stanford data a little bit more inconsistent. So we weren't sure about that data at our center. We wanted to take a deeper dive. We wanted to look at how many of our patients are truly depressed. So last year I gave this survey called the CESD. It's the same screening tool they used in the TIDES study that was very effective. We gave it to 100 CF adults in our clinic last year. And a score on this being 0 is not depressed at all or the least risk. And the highest score a person can get is 60. The clinical cutoff for depression is 16. So any score that's 16 or higher is considered depressed. So 20% of those 100 patients came back as depressed. And when I scored their test immediately after they took it, I shared the result with them. We had a discussion about the score. I provided some counseling and some education to these patients about depression and about their particular situation, and then they were offered a variety of resources to help treat the depression, such as a referral to a therapist, assistance in setting up the therapy, or other type of self-help. This is looking at the mean depression score by gender. Similar to that other study, not a lot of statistical difference between males and CF females by depression score, according to this data. This is the mean depression score by age cohorts. some difference there, however, kind of hard to generalize because of the big differences in the numbers. So follow-up for 2013. So starting this year, I took that group of 20% of patients that tested positive for depression, and I went ahead and gave them a post-test, the same test. And I scored them again. And I haven't gotten to all of them yet, but I've gotten to most of them. And so far, the scores are coming down significantly. 79% of the scores have come down by quite a bit. And 57% of the scores are coming back as no longer depressed, meaning under 16. So what does that tell me? That tells me that just by giving the screening tool and by having a conversation is raising that patient's awareness about depression. They might not have even recognized that they had it. Additionally, the referral to the therapist and their following up on that referral could have resulted in their depression being eliminated. So if we were to do this with all of our patients, not just this group of 100, I think there's great implications for chronic disease management in CF and even beyond. So as Paul mentioned in his talk, we're hoping to turn this into a study, a retrospective study, just looking at depression and linking it to other health metrics, and maybe possibly setting a new standard of screening for the CF Foundation, so other centers can follow this, and we can recognize depression earlier, we can prevent depression, treat it, and hopefully avoid suicides and other kinds of problems that arise from depression. So in moving forward from this, we see that screening is very valuable, it's very important. And so this is the tool that we're considering using moving forward. It's called the PHQ-9. It's a very valid tool, and it's used often in primary care settings. And it's only got 9 questions. It doesn't have 20 like the other one. And for patients who aren't depressed, they just fill out the first 2 questions. And if they score 0 on the first 2, they're done. They don't have to fill out the rest of it. If they score more than 0 on the first 2, then they go ahead and they just complete questions 3 through 9. And then it's got a very easy scoring system, and I can give them a score right then and there that tells them mild depression, moderate depression, or severe depression. And then once again, we have a individualized conversation, some counseling, and a referral to a therapist or treatment program. So in terms of treatment for depression, there's no real one-size-fits-all approach. And for whatever reason, I can never figure out, patients have a very difficult time following up with recommendations for therapy. For more severe depression, we strongly recommend that the patient go see a psychiatrist for consideration of the right type of medication. There are numerous different medications out there now that treat depression, that treat all depression and anxiety together, that treat a variety of other things. And it's important that a psychiatrist do that and not somebody from the CF team. And some patients are able to get these medications from primary doctors. However, a psychiatrist probably has the best knowledge. But we know that taking a pill doesn't cure depression. It might help some of the chemicals in the brain, but it certainly doesn't give you coping tools and skills to help manage mood changes throughout the lifespan. So I think the best approach is referral to a psychiatrist as well as a therapist for more severe depression. Of course, that doesn't work for everyone. Not everybody wants to see a therapist. Not everybody has the resources to, although we're making that much easier. There's other self-help strategies. Exercise, I think, is one of the most effective non-pharmacological treatments to elevate mood, improve memory, and just enhance your well-being in general. And coincidentally, it's also a form of airway clearance for CF. So this is a great therapy, and most of our patients, minus just a few, are able to have an exercise regimen that works for them. I think faith-based programs work very well, not only because they're giving the patient internal tools to cope through prayer, through faith and healing, but they offer a community of support people and a place to go. Group support I talked about a little bit earlier this morning. Come to my support group. Talk to me about getting a peer mentor. There's many other ways I can help you get linked up in the CF community, and this is a way to help validate a lot of things you may be hearing and feeling, but you don't have a place to talk about it with other people that really truly understand the way only a person that has the same disease can understand. So I think there's incredible power in that. And then mindfulness-based stress reduction, meditation, hypnosis. These are all powerful agents to help with healing and coping and not being so reactive to stress and other moods. In fact, this is a self-hypnosis CD. Has anyone seen this before? This was put out by CFRI this past summer at their retreat, and it's really, really cool. And I have a whole bunch of them in my office, thanks to the Living Breath Foundation, so I can give these out. It's not particularly for depression, it actually is for motivation. But I think the concepts of self-hypnosis can treat just about anything. And last but not least, this is a flyer that was put out earlier this year by CFRI. It's a free counseling program through USC Telehealth. And it's for CF patients and families and even couples. And then you get 12 sessions for free. All you need is a kind of a newer computer, high-speed internet, and a webcam. I just called these people to find out, are you full? Do you have space? And they were super responsive. They said they have plenty of space available, that the intake process is easy, and that from the time the patient calls to get the therapy to when the therapy is delivered is a very short process, a couple of days, in fact, which is not common in other settings. There's also another program very similar to this, through the Peter Judge Quality of Life program, also known as the Community Center for Health and Wellness. This is their brochure. I give these out all the time in clinic. So if you want one of these, this is a more local program that does a similar thing. They can also provide the therapy in person. Their address just moved to East Meadow Circle in Palo Alto. So that concludes my talk. Questions?
So Meg, I have a question.
Mm-hmm.
You commented about the study you're doing. You said 20% of the patients who identified a risk for depression,
Mm-hmm.
and then you reassess them
Right,
X period later.
right.
Of those people that you reassessed, did they all of them go through some type of therapy, or did some do nothing and they just got better on their own?
Some did nothing and they got better on their own, but they were all counseled about their depression. They were made aware of their depression, and they were told about their score. And so, the scores that were much higher, I provided education to them about the severity of their score, and that I strongly recommend, that they see someone. And then I offered assistance in helping those patients set up therapy. But as I mentioned, that it's very hard to get people to actually follow through on that. I've noticed that throughout my entire career, 15 years in social work. Nobody likes to go to a therapist. It's difficult. Yeah.
What amount of time and frequency is your exercise and benefit in depression? Like,
For a general person or a CF patient?
either one is fine. Can you state the question and then
Mm-hmm. So Cammie asked, what's the amount of exercise that you recommend for the best benefit? And I think, if I remember from what it says in the research, is 3 times a week for over 30 minutes at a maximal heart rate of over 60. Does that sound right, Paul? Yeah. Yes. And minimum. So if you can do more than that, great.
Does the wearing of your vest account for any type of exercise therapy since it is just wall manipulation? Or
Exercise? I don't think so.
The
'Cause-
reason I ask is because what I read one time in a depression lecture was that it's the release of endorphins during exercise, and the chest wall movement is somewhat similar to that, and I just wondered if that would count. And I've had people ask, well, I exercise because I vest.
I think it's different. I think it's different, because I think you have to get your heart rate up above a certain amount for a certain length of time to actually have that kind of cognitive benefit and that physiological effect that you talk of. Yes?
That PHQ-9 test that you're talking about?
Mm-hmm.
How often do you do that with your patients here at the adult side?
So she asked about the PHQ-9, this thing right here, about how often we're going to be giving it. And we actually haven't started that yet. This is sort of something we're doing this year, like now. So we're thinking, what, 2 times a year? Twice a year.
Will the LPCH site also? With the kids?
Well, for now,
I don't know.
we've incorporated into the adult program. We've actually been meeting quite frequently with Dr. Mila, and this project, we're going to actually try and present this at the CF Foundation conference, national conference. So inevitably, I think it would be nice to merge both programs and have this done as well. Yeah?
Yeah.
It's a great suggestion.
I mean, I think it would be so nice to have more routine standards with the CF Foundation, like all these other areas that they, say, that they want the CF centers doing. Depression needs to be one of those things. It just isn't yet. Yes.
With Dr. Alexander Prittner's trials, TIDES trial
Mm-hmm.
study, she mentioned that some of the depression that she had found was actually the mirroring of the parents who themselves had depression and how the child sort of grew up and coped. Do you think that this would be beneficial to not only give to, if we do decide to incorporate, to not only give to the child, but also to give to the adult that's parenting?
She asked about the TIDES information and, oh my gosh, giving a screening to a caregiver or a parent, and they were actually doing that in these studies. They were assessing caregivers, in the TIDES study, they assessed caregivers and patients ages 12 and up. So, and
That we would do if we're going to do this combined.
I'm not sure if we do it in the adult population, we'd have to talk about that, but certainly in the peds population, because the parent is the one that's driving the bus for the child. Am I supposed to finish now? Okay.
So thanks, everyone, for coming. I would actually appreciate, we're actually doing evaluations for all of us. If you could please give your input. I think that a couple of these speakers, their names are not on the evaluation form, so if you can just write their names in for specifically the reproductive endocrine talk as well as the social work talk. I think those are the two that need their names in. But this will help us for future years to actually improve and to kind of suggestions that you might have for us to actually make it better next year. But thank you all for coming.